All right, so I'm Joe. I do the breathing test at Stony Point. I have been doing it for the last 22 years. So day in and day out. I'm not very good at public speaking, but I figured since I've been doing this for 22 years, I could get through this one. Today we're just going to talk about PFTs. Why we do them, what I look for, and basically what they consist of. So for the pulmonary function test, basically I just instruct the patients to perform different breathing exercises and techniques so that we can measure the patient's volumes, flows, air trapping, and their gas exchange. So a typical full study consists of spirometry, and you can do that with albuterol. So we would do a spirometry test. It's typically the first test you all do when you get in there, where you take a big breath in and blow it out real hard. We can give that with albuterol, a medication, and then perform the test again. And then we can measure lung volumes. Lung volumes is the second test we typically go on to, where we measure their air trapping and their slow vital capacity. And then the last test we do is the oxygen diffusion test, making sure the oxygen is getting from your lungs across the membrane and into your heart. But PFTs basically help us diagnose or detect any abnormalities in their flow volume loops. So when if you all have a printed out version, you'll see a flow volume loop on the printed out version, and that tells us a lot by it. We can see flow artifacts. We can tell if they have any vocal cord dysfunction. Basically, we can tell if there's this is an obstructive or restrictive disease based on their flow volume loops. The more concave that loop looks, the more obstructed that loop is, your lungs are. Your flow is going to be decreased if you see a very concave flow volume loop.
You're talking about the chart?
The chart, yes. Well, where it comes in, you take a big breath in, and when you blow it out real hard, it either comes straight out, where you get it all out in 1 second, or it may take a long time to a very concave flow volume loop.
And that's on the spirometry phase?
Spirometry,
Yeah,
yes.
that's what you're on.
Tests, CT scans, stuff like that. If you look at it, all the tests together, they get a better idea of what lung deficiency the patient might have. I categorize it, me as a technician, categorize it into 2 categories. It's either the obstructive or restrictive disorder. And we kind of talked a little bit about that. Obstructive is when it's your airways are swollen, decreasing the flow, where you're not able to move air in and out as easy as you would like to. You might hear that whistling and wheezing noises. That comes with a lot of excessive contraction in the smooth muscle, will cause inflammation. And then those 5 diseases over there are the obstructive disorders. Restrictive, same thing, it decreases the, same thing as I talked about earlier today. It decreases the volume in the lungs, so it's harder for the patient to take that big deep breath in. You're losing dead space too with a restrictive disorder, so that space in the bottom of your lungs is where your oxygen, your gas diffusion is taking place. So the smaller your volume is, the smaller the space for the oxygen to diffuse. Just some examples of the restrictive disorders there at the bottom. And then I put it here where I look at their volumes and flows. Those are most important on your spirometry. The FVC and FEV1 tells us a lot, and that ratio also tells us a lot. But the total lung capacity may increase with obstructive disorders because of the air trapping. And a restrictive disorder, the total lung capacity will decrease. There's not gonna be any air trapping at all, because their volumes are minimized. Normal values based on the height, weight, age, and gender. We just talked about that. And now, this is what we consider normal. People, some of my patients are like, oh, I'm only at 85% of predicted. Well, that's what we consider normal. Anything between 80 to 100% is considered normal, both on your flow and your vital capacity. Then we move it into ranges such as mild, moderate, severe, and very severe.
Is that on the report?
What is normal?
Yeah.
This range?
FEV1, is that on the report?
Oh, FEV1 is.
Where are we?
It should be the second one. Yeah, damn. So, mild falls in that range between 65 to 79%. That's for both flow and volume.
You're moderate.
Then we move down to the moderate, 50 to 64. Anything less than 50% is in the severe category. These are things we look at for if they qualify for transplants, if they qualify for valve placements. You can place valves in your lungs now. We basically look at the FEV1 is very important for that, and the vital capacity. Normal range falls in the 80 to 100%. That includes DLCO too. That's your diffusion, oxygen diffusion. That needs to fall within the 80 to 100%.
Wait, could you say that again? Diffusion, is that on the chart?
Yes, that's gonna be at the very bottom. That's the last test we do.
DLCO?
Yes.
DLCO.
So what were you saying about that test?
Anything between 80 to 100% is considered normal for that as well. Volumes, flows,
Percentage of predict?
percent predicted.
It doesn't interpret, it just gives you the numbers.
Yes.
And the doctor's
This
the one
key
that
is, research I have from my pulmonary function books.
Well, that's why we're glad to see you.
Yeah, this I just pulled off there, but that's this is the key I kind of look at. If your percent, and I tell everybody, I gave it in a little bit different. I leave off the very severe part, but I tell everybody, if you're 80 to 100, you're considered normal. If you're 60 to 80, it's a mild deficiency. If you're 40 to 60, that's a moderate severity, and then anything less than 40% is considered severe. That's how I process it in my head, but this is the book. This is actually how the book does it. So it's just gives you an idea, a range of where you are.
Could we order the book off Amazon?
Well, you could probably Google it. Save a couple dollars and just get it offline.
The Pulmonary Fibrosis Foundation has some stuff you can get on how to look this stuff up and how to read it. So if you go to the Pulmonary Fibrosis Foundation's their website, they have a whole section on this.
Oh, thank you.
And you can look it up, and it talks about some of these things on the norm, and that's helpful.
Yeah.
And I just had, you just gave us this percentage, and what you're really talking about is the FEV over
The ratio.
the ratio, and then you jumped into the other one, which I think you're gonna cover a little later, which is the diffusing capacity one.
Yes, and I'll go back to diffusion, but yes, diffusion is the same thing. It's 80 to 100%, these same categories.
But is there, sorry, but on my chart, it has ratios of DLCO to VA, is that what you're talking about?
No, the ratio, I don't look at that, that's the alveolar diffusion. I don't really look at that one. I would look at your actual and then your percent predicted.
Okay.
Do you get yours done at VCU? No, okay.
I can follow up later, I'm just trying to learn how to read it.
Yeah. It's probably, I would just look at the actual, because they may change things. We may not use the same calculation at VCU that they use at Bon Secours.
That is a very
So-
valid point, folks. Every facility has their normals, their normal range, just like in a blood test. Sometimes those normal ranges vary a little bit. So if you're getting it done in one facility, you may have to have it repeated if you go to VCU, because their standards are a little bit different. And they wanna know exactly where you are that day. So they will probably redo a pulmonary function test if it comes from another facility. I don't know of any, facility that will take another facility's carte blanche. They're still gonna wanna do their own. So just know that if you are referred to another institution, they'll wanna do a pulmonary
They'll
function
probably
test.
want to repeat it.
Let me ask you this. When you go from, let's say, pulmonary associates over to VCU, and you have results, EFTs from both organizations, is there any standardization in the testing equipment that says, your actual DLCO would be consistent reading from one facility to the other facility? Or is there equipment and testing variation that says they wouldn't necessarily agree?
Well, I do know they're probably not gonna agree, for the most part, because of many different reasons. They're using a completely different machine than we do. I'm not sure what calculation they're using right now, but it was different. It definitely was at one point. I don't know.
I'm not asking about, percent predicted or anything like that, I'm just looking at the actual measurement value.
And then you also need to make sure the height is exactly the same. If somebody else is heighting you, it's gonna throw it way off. If you're off, if they heighted you a half inch or even an inch taller, then we heighted you,
That doesn't change
that'll
the
throw it
absolute
off.
value, does
Hmm.
it? That doesn't change the absolute value.
No, it'll
Something
change the
predicted.
percent predicted, but the
Right.
actual, that's why I tell everybody, look at the actual
Right.
numbers, because that tells you, even if they change if you go back to the same place, like VCU, if you came to VCU and got your PFTs done this time last year, it'll look totally different. So that's what the percent predicted, but the actuals will be the same.
But that's one of the reasons why they will repeat the test in the facility that you're going to, so that that's the great equilibrator right there.
Yeah. I know that Dr. Perales, he'll repeat them for sure, and he likes to get them done every 3 months sometimes on patients, so. And in normal values, if we go back here to this, these change
What
with
happened to the-
providers.
Did it go to sleep?
Oh, here we go, hold on, maybe it just went to sleep. There we go. All right, so these normal values in mild, moderate, severe, ranges will change through providers. Providers in their head will be like, oh, that's normal, or that's fine, that'll be, they just interpret it in different ways sometimes. So I have to kind of memorize whatever physician likes and what they think is normal. Okay, going back here. So normal, this is the percent predicted, but that's normal for volume, flow, diffusion, and total lung capacity if it falls within the 80 to 100%. The ratio of the FEV1 and the FVC must be greater than 70% to not be considered an obstructive disorder. So if the ratio is greater than 70 and the volume and flow are both of it above 80%, then that's considered normal. If you are looking at a ratio percent less than 70, then you are probably, you probably have an obstructive disorder that we would most likely treat with a bronchodilator. And we'll talk more about that bronchodilator shortly, but let's move on to, we're gonna get into spirometry in a detailed way here. This is what I look at, oh wait, hold on. This is what I look at on the screen, is loops that look similar to this one. I have to make sure that all of the criteria is met and all the tests are performed correctly so that we get some accurate readings that the doctors can interpret. For spirometry, forced vital capacity, that's that first number on there. That measures that vital, your volume, how much air you can get in. And it gives us, it gives us a slightly accurate number of the vital capacity, but like I said earlier, that slow vital capacity is gonna give us more of an accurate reading of your capacity, how much air you can really get in versus your forced one. Forced expiratory volume in the first second, how much air you can get out. Obviously, if you have a narrow diameter, you can't get much air out in that first second, but the larger that orifice is of the airways, you'll be able to get more air out in that first second. Peak flow is something I also look at. This, and the ratio for asthma. Both are kind of give us an idea of where their asthma is at this point, if they're having an exacerbation or if they're having an episode. We try to look for those during the flow volume loop. So, and like I was telling you, the more concave it is, the more obstructed they are. And we can even go even more obstructed. So here, the blue line is a normal flow for the patient. Then the red line is probably, you're looking at about 60% of flow. And then this one here is probably about 30% of flow. So they're only working with about 30% of the lung function flow.
So what if the red and the blue kind of track together? Is that good or not good?
Well, we would do a pre. If we did a pre, then in a post, a pre and a post, we would like for it to kind of go together. But if I get in a pre, if we go in and you do your first spirometry effort and I get this, and then I go and get something like this, I can't take those results. I have to get 3 that are consistent with each other, and then I can report it. So if they don't look similar or they start blending together, then I'll be happy if they blend together, but if they look totally different from each other, then I can't report those results.
What about the line?
Guys, let's use the microphone if we can.
This one is gonna be your flow vital capacity. So this is your inspiratory loop. And during your inspiratory loop, I have you take a fast, big breath in. And if you take a fast, big breath in and you have a loop that looks like this, there's no vocal cord dysfunction. But if you're, or I should say, there's no obstruction here and there's no vocal cord dysfunction. So this will show us upper airway obstruction and any vocal cord dysfunction. So if you take the big breath in, your vocal cords are responding, they're opening up, and all the air is flowing in. Now, if it takes a long time and it's flat, it's taking a long time to inhale, there's probably a fixed obstruction in your upper airway for some reason. Maybe a tumor, maybe I don't know. There's different reasons for everybody, but it would take a nice, slow, a long time to take your big breath in if there's a flow obstruction. Also, you can see, sometimes you might see a pattern like a jigsaw, like a saw. That would indicate the vocal cords are paralyzed or they're not working or responding to your inhale, or secretions. They just have mucus sitting right there on your epiglottis or your vocal cords. So, all right, let's see. Any questions after that? That was a good question.
Kind of out of the blue, but I had a C3, C4 fusion, and they put the metal between my vocal cords and my spinal cord and it reduced my vocal cords' ability to contract.
Oh, really? Do you
Yeah.
see it on, do you see it on?
I see the loop there,
Flattening?
it's a
Okay.
little flat, but I'm just wondering if anybody's even looking at stuff like that.
I know they are, or most of the physicians are, unless, you've been in several times, they know what they're looking for. You come in every 3 months, then they don't really look at that as much. But every time, first time, if you're coming in and you're getting a full study done, for the first time, they're looking at everything.
So I should mention that. Okay, thank you.
Okay. Good questions, let's see. All right, the ratio. If it is reduced and you have a 70% or lower ratio, that shows us a sign of airflow limitation or obstruction. We see that in our 5 obstructive disorders: COPD, bronchiectasis, asthma, bronchitis, and emphysema. We typically would give a inhaled bronchodilator that relaxes the smooth muscle in the airways to help open them up so you can move air a little bit more freely in and out of your lungs is the idea. The bronchodilator we like to use is a fast-acting bronchodilator, so it'll respond if the patient responds, they'll respond right away. But it won't last long. It will only last a couple of hours. And we like to give it through a nebulizer because the nebulizer version versus an inhaler, the particle size of the nebulizer is much smaller, much finer, so you're gonna get better deposition of the medication in your lungs.
The nebulizer is that machine,
As the machine
it's a
versus
little box.
the little box.
Okay.
Yeah, if you have the liquid kind, that's gonna be better for you, better off, it's just more time consuming. Not as portable, but if you're having a severe case, I would use that versus your albuterol. Not everybody responds.
I was going to ask.
Yeah.
When I had my pulmonary function test at Pulmonary Associates of Richmond, they did the inhaler. And like halfway through, and they said, okay, now we're gonna wait a few minutes and see if that changes your results. We're gonna do this again. And it didn't.
Okay.
But they weren't gonna, I don't mean they crank people out, but they're not gonna wait 20 minutes while you do a nebulizing treatment and do another test.
They used to do the
They used to?
nebulizing treatment years ago, and then they started doing four puffs of albuterol instead of just.
I felt good and hopped up, nice and tacky, but, you know.
So yeah, that's a
One
side
of
effect.
the things that you might wanna, touch on, Joe, is the difference between doing the in-the-box test for pulmonary function versus just the one where they put the clip on the nose,
Yes.
your basic spirometry.
So we're gonna get into that, the lung volumes is when you go actually inside the machine, and we're gonna touch on lung volumes next. But for the bronchodilator, most of my patients respond 2 or 3%, but we're looking for something significant. So you maybe responded 2 or 3%, somebody might feel a little better, maybe they can feel that 2 or 3%, but we're looking for something probably along the lines of 12 to 15%. That will show us that you definitely do respond and that you would require a maintenance medication on a daily basis. Again, every provider is different, so some providers may consider 10% to be greater. It just depends on the provider. But and the book says 12. That's what I'm saying. Okay, here's just a diaphragm. So this is an inflamed airway. This is with treatment. Still shows some inflammation, so you're going to see a reduced flow no matter what with this. And then here you have a normal airway where all the air will probably be out in 1 second anyways. This is what kind of loop I'm looking at on the screen. You see the concavity there, and that's before, the black line is before the bronchodilator, and the red line is post-bronchodilator. So that's after your bronchodilator if you have a significant response to that albuterol treatment that was given. So that's just a visual there. Now we have a couple more visuals, flow volume loops that I kind of look at my screen and I can tell. Normal, all the way in and all the way out. You don't see any concavity there. There's no reduced volume, because here on your y-axis, you're measuring the flow. On the x-axis, you're measuring the volume. Here, you have a nice big breath, a nice big volume here, but it takes you a long time to get all of it out. All right, so that's your obstruction. That's when we give that bronchodilator. This is a restrictive disorder where your fibers, your fibrotic tissue in your lungs are affected. So that's preventing one from taking a deep breath in, getting that deep breath in. You can see where the volume, this is the ideal volume for the patient. They're about halfway where they should be. Their flow is limited a little bit because anytime your volume goes down, your flow is going to go down too. You don't have much volume to work with, so your flow may go down too. But you can see that the volume goes down here and the flow slightly goes down. Here, you're going to see you see concavity, and you see a reduction in volume as well. So this is a mixed diagnosis here between restrictive and obstructive. All right, so here's the flow volume loop I was telling you about. It's flatter here. That shows that there might be obstruction in the upper airway. Also, if you see little squiggly lines like that, they're either working with probably some secretions or some mucus here. I try to get my patients to cough it up. Take notice if they can cough it up, or maybe a vocal cord dysfunction. That I don't know, I just can see it, I don't know what it is. That would be more diagnostic tests in your future if they find something like that. All right, lung volumes. This is the one where you go inside the machine. At
What kind of machine? What machine?
that big box
Where you sit in there?
where you
Sit in
sit
the
in.
box, yeah.
And what's
And-
that machine called?
That's called the plethysmography box. I call it a body box. And it's,
Yeah, I always sit in there.
yes, and it's, there's one test where we close you in. Have you been closed inside the machine before? No, okay. So the most important tests are that spirometry, measures your volume and flow, and then your diffusion. You want to get your oxygen diffusion rate, make sure that's, you're getting that oxygen to your blood, to your heart. But for lung volumes, they're not always ordered at VCU. I don't know about Von Secours, or Pulmonary Associates, but we don't always order them at VCU, especially if you're coming back as a routine patient and we know you already. Then we just want, just for like insurance purposes too, you don't want to get anything extra you don't really need. So this is important for any obstructive disorders, COPD, emphysema, asthma. The lung volumes where you go inside the machine, we measure your mouth pressure. We use a Boyle's law to determine how much air is trapped in your lungs at indexation. And that's really important. The residual volume here is what we're measuring. So for the obstructive disorders, we have a lot more air trapping. The slow vital capacity is also performed in the lung volumes. That's where we can get an accurate reading of the big deep breath in, and then you blow it all out. If you add the vital capacity and your RV together, you get your total lung capacity. So once we close you inside the machine, we use Boyle's law, which is a P1 times V1 equals P2 times V2. P1 and V1 are the box measurements, and then P2 is your mouth pressure that I'm measuring while you're in there, and then that'll help us to determine the V2, which is the volume still left in your lungs at end exhalation. Any questions on that? Okay, it's a lot, it is a lot, but like I said, if you have an obstructive disorder, you'll probably have more air trapping because those airways are inflamed and,
Okay, so
are blocked.
we have a chart here in VCU, it's in 3 colors. Does this relate to those areas you have blocked in there?
Mm-hmm, yes.
Like it goes across the whole top,
Mhm.
that black one? What would that be on your?
No, this is, so
Presentation.
this is gonna look different. This is just giving, this is, it looks, well, I'm guessing this is your RV. It's just giving you, but the chart is different, but the information. So you're gonna measure your inspiratory capacity, which is the dark line here, and your residual volume, which is air trapped in your
The
lungs.
the IC and the RV?
In the RV, yes, the residual volume. So that's air trapping, and that would be down here. It's kind of hard to determine with the graph, but that's what the numerical data is for. Did you get? Is there another page?
Is that it?
It should be the same one.
If it's a obstructive disorder, that's something we monitor.
Okay, I'm sorry, but I don't know what you meant when you probably defined it at the beginning, restrictive and
Obstructive.
obstructive. Could you redefine those again? please?
Yes. So obstruction is when your airways and your lungs that pipe off are tight. They're really inflamed. They're really small.
How can I tell?
You have a restricted.
You'll maybe hear, you'll have coughing, you might hear whistling or wheezing coming from your chest. Sometimes, maybe it's
I
positional.
don't have that.
So
And everything else is
the
restricted.
flow is reduced on obstructive disorders. The restrictive disorders, your volume is reduced. You can't take a deep breath in. You can take a deep breath in with an obstruction, it just takes you a long time to get that breath in. Whereas a restrictive disorder, you may never get that big breath in because
So
that fibrotic
IPF
tissue is
is
damaged.
what's IPF?
Restrictive.
Restrictive, IPF?
IPF is a restrictive disorder, any interstitial
That's what I
ILD,
have, IPF.
and then, COPD, asthma, obstructive, bronchitis. And then pretty much anything else, other than those 5 diseases are restrictive
Okay,
disorders.
thank you.
All right, and it's gonna look black on the CT scan. I think you're talking about, they're showing you a picture of the scan, and they're saying the white part or the, spotty
I just,
honeycomb. Okay.
I heard that I had scarring on the bottom. I don't know if I saw a picture of it, I don't know.
Okay, yeah, the air usually is up here in the upper airways, you have those larger airways, so it's holding more air. And so it's gonna look dark on your scans, is all up here. Your lower airways are affected first, they're smaller, they're more friable, they're, easy target, like a weaker, almost like a, weaker. But they are affected first, and that shows up first on the, CT scan.
One more, since I have a question. Should a doctor be able to look at a PFT results and determine whether I am able to fly commercial without taking supplemental oxygen?
I think so, for the most part.
That's that gives them a good picture of where I am.
Oh, yeah, and I think I remember your numbers earlier, and I think you would be fine flying commercial. Yes, I don't wanna say who, yeah, go with whatever the doctor says, but they'll be able to look at your results and
Okay,
tell you
all right.
if you're safe to
Is there
fly.
any test you would actually do in a PFT to answer that question?
Huh?
Is there any additional tests that can be done in a PFT to help answer that?
If you're safe enough to fly.
Do you do an altitude test? Can
We
you do
don't,
that?
I don't do them. I don't know if, but I've never seen them do a test for that.
Okay.
There's something called a HAST, H-A-S-T. And I don't know who does it, I had to go up
Yeah, it's a high
to
altitude.
UVA.
Oh, yeah, I don't know that we do it at BCU, so I'm not sure about that. Very good questions though. Okay, diffusion. So we have, I have, for me, in my job, being the tech, I have to make sure that the data I obtain and measurements I obtain from the patients, meet criteria. And I just listed a few of the, errors that I might see or stuff I look for here. First of all, that's, flow volume loop. That's the most important one. I gotta make sure that they have a great start, that you basically blast it out right away. There's no delay. A lot of times people don't even realize that they think they're still inhaling, but actually air is leaking out, and then they blow out. But then I stop them right away. Let's repeat it. I also have to make sure there's no leaks. Sometimes if you blow real hard, your cheeks fly off the, even though you all may not notice it, the machine picks up every little detail. So, you also have to make sure that you're blowing out till empty. There's a lot of times where you all might feel like you have blown out all your air, but really you haven't. You have a lot more air in there, but you have to squeeze it out, use muscles, all your muscles, tummy muscles, chest muscles. So I use the American Thoracic Society, or here at BCU, we do. We use their guidelines, and try to meet all of the criteria that they've given us. So we have, adults have to exhale for 6 seconds, children have to exhale for 3 seconds. The volume, the back extrapolation volume has to be less than 5%, so that means they have to take that big breath in and immediately blast it all out. And then I look for flow artifacts in the loop and make sure that there's no tongue. Maybe your tongue might be in the filter, and so that'll cause a flow artifact. Coughing, can't be any coughing within the first second, and leaks, and no leaks. Let's see. All right. Then after, one other thing I have to make sure that is met is that there has to be tests that are similar to each other. So you won't believe it, but I have had plenty of tests where 1 second they're blowing 50 coaching instruction, and people understanding it. Sometimes people are getting worn out and they can drop from 80 to 50% because they have a muscle issue, maybe muscle dystrophy, where they just get worn out completely. So I just have to make sure that all results, I have at least 2 results that are within the 15% of each other. And if I don't get that, I have them repeat the efforts as long as they can do it, or up until 8 efforts, because after that, they may never get it. I don't want to keep working them at that point. Any questions on that? No? Okay. All right, so I'm done talking about PFTs in a way. Okay.
Just a comment.
Yeah.
And that is, you're very important.
Okay, thank you.
Because when I go in for a test, how the person doing the test interacts with me is critical. I've got to listen to what you say. I've got to do what you tell me the way you do it. And I've only gone through 3, but I had 2 different technicians and I got totally different results.
It matters. You're doing a test for no reason. It's all effort dependent, and if the person's not coaching or demonstrating, people might need demonstration versus verbal coaching. You just have to know the patient, and then you all will know
how to pay attention to you.
Yeah, and then you all might want the same technician that you had before. You're like, oh, this one works really well with me. I understand this provider versus.
Now, can I request to come over to your
I have
place
plenty of.
and you do that
Yes.
just to have the consistency and.
Oh yeah, if you have Dr. Perales, then he's
He's okay with that?
Yeah, because he was over there at Stony Point, so there's a lot of patients that started over there with me, and they want to continue with the same booth, same tech, everything the same, so they get consistency.
Yeah, that's,
Just like I said, if you're going somewhere else, even techs, it may change, your numbers may change, just because, you know, yeah. So
I'm coming to.
okay, yes. Yes, ma'am.
So sometimes I hear people say, oh, my lungs at 65% capacity. And I don't know what on that chart they're talking about, or if that's any such thing.
So if they're saying they have 65% of capacity, they're saying they're only working with 65% of that volume, whereas 80 to 100% is normal. So they've lost some capacity there. So there is some fibrotic tissue damage somewhere in the lungs.
So it'd be the FBL.
It would be the, no, FVC, so forced vital capacity. Yeah, FVC. And this is just the loop, it's the whole thing, the flow volume loop. But, and then obstruction, if you have an obstructive disorder, your most important number is FEV1, okay? And if you have a restrictive disorder, focus on the FVC, the vital capacity, okay? There's some important numbers. Restrictive, look at the FVC, the vital capacity. Obstructive, look at the flow, the FEV1, okay? Both affect your diffusion rate, so always look at your oxygen diffusion, always look at that.
Joe, this has been so
really?
helpful. Do you have any of the further on slides that you want to speak to briefly? Just for the sake, I know we started late. And anybody that needs to leave, please feel free to. I think they're not gonna kick us out, so,
She said she would send a slide.
Yeah, if we can get the slides, that would be great.
Yeah.
Is there anything that you haven't talked about on?
No, I pretty much covered everything, and I shared the most important things, when looking at a PFT, I think, and what numbers are most important to look at. And then I touched a little bit on the diseases that the obstructive and restrictive disorders. But that's,
Well, Joelle, thank you so
no
much.
problem. You're quite welcome. Ours looks a little bit different. That is your percent predicted. So they take this and divide these two, times by 100. That means it remeasures your volume and flow again after you've got these medications. So they selected the medication accepted it. Okay. And it does look like you changed after which one it gives you 77% to 79%. So you didn't improve by 2 or 3%. 2%. Well, that's the whole. So you don't have a reactive airway. It's not twisting your